Hello, this is Dr. John Odette. Today I will be presenting a case of an IOL exchange in a patient that is a monofocal three-piece lens that will be exchanged for a different power monofocal three-piece lens. This is an unedited version, so you will see some pauses during the case. We've started the case by making a paracentesis, and we're injecting some intraocular lidocaine. We will follow this up with some generous amount of viscoelastic in the anterior chamber. At times during the case you will see pauses. Those are normal pauses that occur during the surgery. You will also see a few occasions where the patient's eye moves or twitches. In this part of the case, I am opening up the primary cataract incision with a Donenfeld LASIK flap applanator. This patient was about 4 to 5 months post his initial surgery and desired a refractive IOL exchange. He wanted more near vision. He was a previous LASIK patient and previously did well with monovision and did not get the refracted outcome from his initial surgery. You can see that I went in with the LASIK flap applanator and separated the anterior capsule from the lens, and now I'm injecting some new visc around the lens. This is simply using a 27 gauge cannula. The most important part of this procedure is to get a fair amount of viscoelastic around and behind the lens so as to be sure not to damage the posterior capsule. Here you can see I've actually gone under the intraocular lens, so I am now confident I have a fair amount of viscoelastic behind the lens, and I'm gently teasing the lens out. This is a three-piece lens. Sometimes the haptics can be pretty well socked in. At this point, I've decided to come out of the eye with the viscoelastic, and you'll see a slight pause while my scrub tech gets a collar button for me. I do like to use a collar button to spin the lens out of the bag. This one spins out fairly freely as the initial cataract surgery was done relatively close to this one. The haptics were not terribly socked into the bag yet. I have now spun the lens up into the anterior capsule. Anterior chamber. You can see that the lens is sitting in the angle. The haptics are sitting in the angle. I then refill both posterior and anterior to the lens with viscoelastic to ensure that the endothelium will not be damaged and that I have plenty of viscoelastic protecting the posterior capsule. You can see I've got a little pause here once again. I load my lenses myself, and I will be injecting a three-piece Bausch & Lomb Li61AO lens behind the initial lens. We wet the cornea again, of course, but the lens will slide in nicely right into the bag as it normally would. This compresses the space that you have to work with slightly, but I find it's a better way to protect the posterior capsule if in fact the capsule is intact and it's a fairly straightforward case. Now I will use the MST micro forceps. These have teeth on them, and a micro scissors also made by MST that is a intraocular lens cutting scissors to cut the lens. I prefer to cut it all the way through. You can see even a fairly firm silicone lens cuts pretty easily. I will then go back in and use the MST forceps. I align the lens how I want it to come out of the wound, and it comes out fairly easily. The first piece is out. I will go back in and rotate the second piece so I have as atraumatic a removal as possible. In a second here you will see the patient grimace a little bit and squeeze his eye. There was the squeeze. I maneuvered the lens a little too close to the angle of his iris, and I do find that after having cut an IOL, that the edges are slightly more jagged, and the patient feels it if you in fact touch their iris or anywhere close to their angle. I went back in with the MST microforceps and removed the remainder of the lens. It came out very easily. You can see I've recentered. I was off center a little bit there. As I mentioned, this is an unedited case. So at this point I already have the lens in the bag. I will go back in with my irrigation and aspiration cannula and rotate the lens, make sure it is sitting nicely in the bag. You may have seen to start the case that the initial capsulorhexis was continuous and curvilinear but slightly inferiorly displaced. So I have aligned the haptics at what is 9 o'clock and 3 o'clock in the video. However, this is inferior and superior as it relates to the patient's anatomy. I am removing the remainder of the viscoelastic, both anterior to the lens and posterior to the lens. I've rotated it again, but didn't like how it was seated, so I rotated it back to the original position. I will then hydrate both the paracentesis and the primary wound. I prefer to hydrate rather aggressively in a young, healthy patient. This is usually not too much of a problem. If endothelium is in fact concerning to me, I would not likely hydrate as much as I have in this case. The lens, you can see, is seated nicely inside the capsule, and this will complete the case. This case took just over 6 minutes to complete. I do not think that I have incredible skill in completing a case this quickly, but I do want to mention that with the right tools and the right instruments, performing the procedure correctly can go smooth and quite quickly for all anterior segment surgeons. Thank you for observing this case.